videos that demonstrate range of motion in the intubated patient. These exercises can be performed during bathing and routine repositioning. Range of motion maintains muscle strength and, if done frequently, can decrease the patient's length of stay. This is one of the first steps in mobilizing our critically ill patients.
Range of motion is very important. You want to do these motions slowly and gently. By executing these motions slowly and gently, it enables you to assess how the patient's joint is moving as well as to monitor how the patient is responding to these motions. Towards the end of their range, you will feel tension or resistance, and this is called an end feel. It's very important to not push past this end feel because that could injure the patient. Another thing to monitor on the patient is their facial expressions. Even if they don't verbally tell you that they are in pain, most patients will wince or grimace. If you see this, only complete the range of motion within their available pain-free range. Lastly, repeat these motions 3 to 5 times on each side.
So we're going to begin bathing our patient. We're going to bring the bed up just a little bit. And typically we bathe from head to toe, so we're going to start with the patient's face and neck.
After you've washed the patient's face, this would be a good point in the routine to do some neck range of motion. We're going to do turning and something we call side bending. We'll start with turning first. You want to make sure that you have enough slack on the tube, and you're going to gently place your hands on either side of the patient's head. You're going to slowly turn their head to one side and then to the other. So that was turning or rotation. Next we'll do side bending. You're going to place one hand on the opposite side of the patient's head and one side on their neck on the same side. You're going to bring their ear to their shoulder and back up to neutral or midline, which is when the head is straight up. Good. If you're working in a pair, another person can do it from the other side. If you're working alone, I recommend going to the other side of the bed so that you're always side bending towards you. This gives you more control over the patient's head and allows you to better monitor their facial expression.
Next, we'll move down to the patient's chest and torso. And just cleaning underneath the arms also.
After you've washed the patient's torso and their underarms, this would be a good time to do some shoulder range of motion. You're going to place one hand at the far end of the upper arm and the other hand at the far end of the forearm. You're going to slowly raise the patient's arm towards the ceiling. So you're on the distal end or the far end of the upper arm and the distal end or the far end of the forearm. It's important to note that with the shoulder, motions may not be symmetrical on either side due to injuries or surgeries. Therefore, it's important to look out for the end feel and not push the patient further, and don't compare it to the other side. Keeping your hands in the same positions at the distal end of the upper arm and the distal end of the forearm, you will now bring the patient's arm out away from their body. This is called shoulder abduction. A very functional range for this motion is a 90-degree angle between their torso and their arm.
At this point, you can go on and start washing the patient's legs.
After you've washed the patient's legs, this is a good time to do some ankle range of motion. You're going to first support their lower leg, and you're going to use a C grip, making your fingers into a C and placing your hand on either side of the patient's foot. You're then going to gently point the toes down and then point the toes up towards the ceiling. When you're pointing the toes down, this is plantar flexion, and when you're pointing the toes up, this is dorsiflexion. After you're done, you can then wrap your hand around the patient's foot and grab their heel. You're going to use your forearm along their bottom of their foot, and you are going to lean towards the head of the bed. And this is going to dorsiflex their foot and stretch their calf. It's important to hold this for at least 30 seconds because these muscles get very tight in patients who are laying in bed. When you're down towards the patient's feet, you can also do some hip range of motion. You're going to grab the back side of their thigh and the back side of their lower leg right above their ankle. You're going to slowly bring their legs out away from each other and then back towards each other. When you're bringing their legs apart, this is called hip abduction. And when you're bringing them together, it's called hip adduction.
Now, before we lower the head of the bed, we're going to clean out the patient's mouth and then suction the endotracheal tube. And then we're going to put your head down flat. Undo that restraint, and I'm going to have you turn towards me, and we're just going to wash your back. Bring this arm over here. You can hold the railing.
After you've washed the patient's back, this is another good time to do some more hip range of motion. You're going to grab the inside of the patient's knee and the bottom of their foot, and you're going to bring their knee towards their chest, bending the hip and the knee, and then you're going to straighten out their hip and their knee. So you're performing hip flexion and knee flexion, and then knee extension and hip extension. And it's important when you're extending to make sure that their hip and their thigh are in line with their trunk, and this is what we call neutral.
Okay, we're going to have you roll over onto the other side. Reach over there.
It's important when you're doing this motion to make sure that you're getting that hip straight, because when patients are laying in bed, their feet are up, their head of the bed is up, or they could be sitting in a chair, and these muscles in front of the hip get very tight. Doing this motion enables those muscles to be stretched, which will help with their standing posture and with their mobility, because straightening the hip is needed for normal walking.
If you want, we can pull you up a little bit, and I think we're going to leave you on your side for a while. 1, 2, 3. I'm going to have you turn on your side. That's good. You can lean back. And then we're going to bring your arm back here a little bit.
At this time, you can perform more shoulder ranges of motion, specifically focusing on turning. You're gonna place your hands on the far end of the patient's upper arm and the far end of the patient's forearm. Bring their arms out on a diagonal slightly and bend their elbows. You're then going to turn the patient's hand away from their body and towards their body. Going away from the body is called external rotation, and towards the body is called internal rotation. It's important to monitor the patient's shoulder on internal rotation to make sure that it is not popping up towards the ceiling. This is not good, and you would like to stop the internal rotation before you see the shoulder popping up. You can then rest their upper arm on the bed. And now we're going to work on elbow range of motion. You're going to gently straighten that elbow and then bring that elbow back into bending. This is elbow extension and elbow flexion. Next, we will perform some wrist range of motions. If the patient has an A-line, you will not do these range of motions on that arm. If able, you can remove this restraint, and you're going to support their forearm with one hand, and using that C grip again, you're going to grab either side of the patient's hand. You're going to bring their wrist forward, and then you're going to bring it back. Bend it forward and back. This is wrist flexion and wrist extension. Next, we'll focus on the fingers. If the patient is conscious, you can ask them to squeeze your fingers. Can you squeeze my fingers for me? Thank you. And spread your fingers out wide for me. Good. And squeeze my fingers. Good. And spread your fingers. One more time. If the patient is not conscious and cannot actively participate, we recommend using your hand and placing it on the back of theirs and gently bringing their fingers into bending. For straightening, bring your hands in and straighten the fingers out, making sure that you bring this thumb out to the side. You're going to flex their fingers and then extend their fingers. At this point, we can do some more forearm range of motion. You're going to stabilize the upper arm, and you're going to gently place your hands at their wrist. You will turn their palm up towards the ceiling and then down towards the bed. Up towards the ceiling is called supination, and down towards the bed is pronation. At this time, we will do another wrist range of motion. Again, if the patient has an A-line, this is not appropriate for that hand. You will stabilize their forearm, and using that C grip again, place your hand on either side of the patient's hand. You will then tilt their hand towards their thumb and then out towards their pinky. When you're moving towards their thumb, this is called radial deviation, and towards their pinky is ulnar deviation. Range of motion is very important to maintain their functional range of motion as well as to maintain their strength while they're laying in the hospital. It's important to remember to use proper body mechanics to bend from your knees and bend from your hips if you have to reach across the bed, as well as don't be afraid to move the bed to the proper height. Lastly, to recap important parts, move the patient slowly. Make sure you're feeling for that end feel and not pushing further. Also be attentive to the patient's face and what they're verbally telling you, and only do range of motion in their pain-free available range. Lastly, repeat these motions at least 3 times, each joint on each side. Thank you.